Okay, let's start with condyle fracture. Okay, condyle fracture is the most common fracture of in case of mandible when there is multiple fracture, and most of the fracture in the mandible are multiple fracture instead of isolated mandible fracture or isolated single fracture. So, in case of condylar fracture of mandible, condylar fractures are very common, representing around 25 to 52% of all mandibular fractures. Treatment policy for condylar injuries has aroused more controversy than any other subject in the maxillofacial trauma, because previously, whenever there was condylar fracture in the mandible, all the condylar fracture were treated by non-surgical treatment. Usually, surgery was not indicated before. Traditionally, all the condylar fractures were treated non-surgically. But nowadays, recently, most of the condylar fracture, or almost all the condylar fractures are treated surgically. Okay. So fracture of the condyle appears always to heal by bony union regardless of any therapy, unlike the rest of the mandible where non-union is always the possibility because of sufficient amount of blood supply, abundant amount of blood supply due to attachment of lateral tibial muscle. There is sufficient blood supply. The chances of non-union is very rare. Unlike other part of the mandibular fracture where if the interfragment mobility is there, then the fracture will go into non-union. So such a complication like non-union do not happen in case of condylar fracture. Direct blow to the distal mandible shocks the joint area, resulting in a condylar fracture. Usually, unlike other fracture in the mandible like symphysis, parasymphysis, or body fracture, where there is direct trauma, but in case of condylar fracture, almost in all the cases there is indirect trauma. Okay, so whenever there is trauma in the symphysis or parasymphysis region, it will lead to fracture in the condylar neck region or subcondylar fracture. If you see the normal anatomy of temporomandibular joint is divided into two parts by articular disc, the superior joint cavity, inferior joint cavity. The volume of the superior joint cavity is about 1.2 ml. It consists of synovial fluid, and the volume of inferior joint cavity is about 0.8 ml. So, as we know, the condyle has two types of movement: rotatory movement and translatory movement. Rotational movement or rotatory movement only takes place in the inferior joint cavity, whereas translatory movement takes place in the superior joint cavity. Okay. The articular disc, as you can see in the figure, the articular disc has neurovascular bundle in the posterior region, and in the if you see the intermediate region where the condyle articulates with the glenoid fossa of the temporal bone, this area is comparatively thin and there is no neurovascular supply. So usually patients do not have any pain. But usually in female patients, and if the patient is more than 40 years, the articular disc gets displaced anteriorly. And in such cases, as the articular disc gets displaced anteriorly, we say that anterior disc displacement with reduction and without reduction. In case of anterior disc displacement, what happened? The posterior band, which has abundant amount of neurovascular supply, will get impinged between the condyle and the glenoid fossa, so the patient will have pain. In the normal condition, patient will not have any pain. Whenever the articular disc is displaced anteriorly, then the patient will have severe chronic pain. Okay. So in late cases, what happened? Due to the displacement of articular disc anteriorly, patient will have clicking sound in the initial stage. Later, in the initial stage, what happened? The articular, even though the articular disc is displaced anteriorly, it can again come back to its normal position. So this condition is known as anterior disc displacement with reduction. Okay. In late cases, as the disc is displaced more anteriorly, the articular disc could not come to the normal position. Such condition is known as anterior disc displacement without reduction. And in such cases, clinically, the mouth opening of the patient will be reduced to less than 13 mm. So there are two types of rotation: movement, rotatory movement, and translatory movement. During rotatory movement, the mouth opening is about 12 to 13 mm or 12 to 13 degree. After 12 to 13 mm, there is translatory movement. Rotatory movement only takes place in the inferior joint cavity, and the translatory movement takes place in the superior joint cavity. So in case of condyle, it is divided into three parts: condylar heads, subcondyle, and condylar neck. As shown in this pink color, it is known as condylar head, or if the fracture takes place within the capsule, inside the capsule, such fracture is known as condylar head fracture. If the fracture takes place below this sigmoid notch, it is known as subcondylar fracture. And if the fracture takes place above this sigmoid notch and below the attachment of the capsule, then such fracture is known as condylar neck fracture. It is also known as high condylar neck or low condylar neck fracture. And if the fracture is present in this area, as shown in green color, it is known as ramal fracture. And if the fracture is in this area, then it is known as coronate process fracture. And the coronate process fracture is the least common fracture because it is present just below the zygomatic arch. Before fracturing the coronate process, the zygomatic arch has to be fractured. So in most of the cases, coronate process do not fracture. If you see the condyle of children and adult, there is huge difference between the condyle of the pediatric patient and adult patient. In pediatric patient, most of the time the condyle head gets fractured, but unlike in adult patient, most of the time condylar neck or subcondylar fracture takes place. Condylar head fracture is rare in case adult patient, but it is more common in pediatric patient. The anatomical difference between the pediatric patient and adult is in case of child, in case of pediatric patient, the cortex is thin, neck is broad, okay, periosteum is very thin, and all the cells which are present within the bone marrow cavity are in active osteogenic phase. So whenever there is condyle fracture, the new bone is formed, and the chances of TMJ ankylosis is more common in case of pediatric patient. But in case of adult, cortex is thick. Okay, the cells which are present in the bone marrow are in latent stage. They are not in active osteogenic phase. Condylar neck is completely thin. It is not broad like in pediatric patient. So in case of adult, the condyle fractures usually at the neck or subcondylar fracture. Condylar head fracture is rare in case of adult, but in contrast, in case of child or in case of pediatric patient, the most common fracture is condylar head fracture. Condylar neck fracture or subcondylar fracture do not take place in the pediatric patient. As you can see in the figure, the condylar neck is broad as compared to condylar head. Okay. The overlying cortex is very thin. The osteogenic cells which are present in this bone marrow is in highly active osteogenic phase. So whenever this condylar head fracture, this bone marrow will get displaced into the joint cavity. And as we know that the cells which are present in the bone marrow are in active osteogenic phase, so they will form the new bone here, and it will lead to TMJ ankylosis. So the TMJ ankylosis is more common in pediatric patients. You can't find any TMJ ankylosis in adult. It is very rare. And usually, if the age of the patient is less than 5 years, the chances of condylar head fracture is very high, and it will lead to one of the most common complication is TMJ ankylosis. So in pediatric patient, most of the fracture are intracapsular fracture or condylar head fracture, which will lead to comminuted fracture of the condylar head. As there is comminuted fracture in the condylar head, all the immature cells which are present in the bone marrow cavity of the condyle will enter into the TM joint, and this TM joint, this highly potent osteogenic cells will produce new bone, and that will lead to TM ankylosis. But in case of adult, as you can see, the condylar neck is comparatively thinner than condylar head. Okay, the cortex is thick. The cells which are present in the bone marrow are in latent stage. They are not in active osteogenic phase, and the most of the fracture which are present in the adult are below the capsule. They are either subcondylar fracture or condylar neck fracture. That's why, as you know, the chances of TMJ ankylosis is more common in case of pediatric patients. That's why in case of pediatric patient, whenever there is condylar fracture, surgery is not indicated. Always we have to do non-surgical treatment, because if you open the condyle, there will be bleeding, it will form the new bone, and it will lead to TMJ ankylosis. So the surgery is always contraindicated in case of pediatric patients if there is condyle fracture. Practically, we don't have to operate any case. Theoretically, they say there are some few conditions where we have to operate the pediatric patient also surgically, like if the condyle is displaced in the medial cranial fossa, if the condyle is displaced laterally, and if it has ruptured the lateral capsule, if it is not possible to regain the occlusion by close treatment, and if it is open fracture, if there is bullet injury. If there is bullet arm injury, then we have to operate surgically in all the cases. Other than these 4 conditions, we don't have to operate. But practically speaking, these 4 conditions are very rare. You can't find any condylar fracture which are displaced into medial cranial fossa, which will not come out of the lateral capsule. Okay, and it is always possible to get occlusion by non-surgical treatment, and the bullet arm injury is also rare. So practically, you don't have to operate any case surgically, but theoretically, they say there are 4 conditions where we have to operate surgically. Otherwise, surgery is contraindicated in case of pediatric patients. So difference between child and adult condyle. The cortical bone is thin in case of pediatric patient and it is thick in adult. That's why the cortical bone do not fracture in adult. Condylar neck is broad in pediatric patient. That's why most of the time condylar neck do not fracture in the pediatric patient. The condylar head fracture takes place in adult. The condylar neck is thin as compared to condylar head. Articular surface is thin in case of child. It is thick in adult. Capsule is highly vascular in pediatric patient. It is less vascular in adult. Periosteum is in highly active osteogenic phase. That's why they form new bone and it will lead to TMJ ankylosis. But in adult patient, it is less active in latent stage. Intracapsular fracture and hemarthrosis is very common in pediatric patient. It is less common in it is rare in adult. Remodeling capacity following trauma is present in pediatric patient, but the remodeling capacity is not present in case of adult. Disturbance in growth is more likely, so it will lead to facial asymmetry, TMJ ankylosis in pediatric patient. It is not present in case of adult. So growth center. Previously, it was thought that a postulated condyle growth center was damaged, which would prevent the forward development of the lower zone. But after the functional matrix theory given by the Melvin Moss, it is soft tissue. They said that the soft tissue matrix play a major role in the growth of the mandible. According to functional matrix theory, what they say, the soft tissue drive the mandible forward, and it will lead to gap in the condylar region, which will lead to the secondary growth. Secondary growth of the cartilage in the condyle, it will lead to growth of the mandible. What the functional matrix theory says that previously it was thought that the growth will present in the condyle, it will pull the mandible forward. But according to functional matrix theory, it is just opposite. What the functional matrix theory says is the soft tissue which is present around the mandible will drive the mandible forward, so it will lead to gap in the condylar region. There will form some gap between the condyle and the fossa. So when the gap is formed in the condylar region, the secondary cartilage which is present in the head of the condyle will lead to formation of new cartilage. And after the new cartilage is formed, it is replaced by the bone. So if you see the bone formation, it takes place by two processes. One is membranous bone formation, one is endochondral bone formation. In the condyle, there is formation of endochondral bone. So the first cartilage is laid down. After that, the cartilage is replaced by bone. In case of TMJ ankylosis, what happened? Due to formation of bone in the TM joint, the temporal bone and the condylar head gets fused. There is TMJ ankylosis. So as the mandible is fused with the temporal bone, the soft tissue matrix could not pull the mandible forward. So the new bone is not formed in the condyle. Previously, it was thought that the condyle is the primary growth center. So growth will take place in the condyle and it will pull the mandible forward. So that concept is wrong. Like after the functional matrix theory, according to soft tissue matrix theory, what they say is the function determines the form. The form do not determine the function. Okay. So during mandibular movement, the soft tissue matrix, which is present around the mandible, will pull the mandible forward, will drive the mandible forward, which will lead to gap formation in the condylar region. Once the gap is formed between the temporal bone and the condyle, the new cartilage is formed. This cartilage is later replaced by the bone, by endochondral bone formation process. So condylar cartilage does not provide a forward drive, but it is purely an adaptive center. After the mandible is pulled forward, the gap which is present in the TMJ region is replaced by the cartilage. So tethering a mandible by bony union prevents it moving with functional matrix. Once the TMJ ankylosis happens, when the ankylosis is formed, the TMJ joint is gone. The mandible could not be driven forward by the functional matrix, so there will be no bone formation in the condylar region. The growth of condyle will not take place, and it will lead to facial asymmetry. And if you see the TMJ ankylosis present, then on the ipsilateral side, where there is TMJ, where the TMJ ankylosis is present, the condylar growth will not take place, so mandible will not grow on that side. So what will happen? Let's say if there is TMJ ankylosis on the right side, there will continue grow on the mandible will grow continuously in the left side, but on the right side, the mandible growth do not take place, so it will lead to facial asymmetry. You can see fullness on the contralateral side and flatness on the ipsilateral side. Okay, that is the characteristic feature of unilateral TMJ ankylosis, because growth takes place only on one side. On the normal side, growth takes place, so it will lead to fullness on that side, and there is no growth on the ipsilateral side. On the side of TMJ ankylosis, it will lead to flatness. So chin is deviated towards the side of TMJ ankylosis. So in such cases, in TMJ ankylosis, we have to release the ankylotic tongue, then we have to address the facial asymmetry. Okay. Usually, TMJ ankylosis takes place in the pediatric patient. If the patient is less than 5 years, chances of TMJ ankylosis is very high. That's why in case of pediatric patient, if there is condyle fracture, the surgery is not indicated, but we have to advise them for active mouth opening. There is something called restitutional remodeling. The tendency of condyle in the pediatric patient to form a neocondyle is very high because they are in active growing stage. All the cells are in active phase. So the new condyle is formed. We don't have to do any surgery. Okay. So whenever there is condyle fracture in pediatric patient, you have to advise for active mouth opening. You don't have to do any surgical treatment, neither you have to do any intermaxillary fixation. Surgery is also contraindicated. Intermaxillary fixation is also contraindicated. You have to advise for active mouth opening. Mouth opening is advised. So what is the age limit where you can consider whether it is pediatric patient or adult? If the patient age is less than 12 years, we consider it as a pediatric patient. We don't do any surgery. If the patient is more than 12 years, then we treat them as an adult patient. So another thing, in case of condyle fracture in pediatric patient, as you know, the TMJ ankylosis is very common. Usually, it is present in the rural area where the better medical facility is not available. So patient will report to you after many years. If the patient, when a patient report to you, if you see the history, trauma might have occurred before 10 to 15 years, or patient might have forgotten the trauma. Okay. So in such cases, TMJ ankylosis is very severe. Facial asymmetry is there. You have to release the ankylotic chunk. You have to do you have to correct the facial asymmetry as well. In such cases, the treatment is if there is TMJ ankylosis in any patient, if there is let's say unilateral TMJ ankylosis, then there is facial asymmetry as well. The mouth opening is not there, so you have to release the ankylotic chunk. You have to replace the temporomandibular joint with alloplastic TMJ material. Okay. After addressing the TMJ ankylosis, you have to address the facial asymmetry as well. In case of facial asymmetry, to address the facial asymmetry, you have to do orthognathic surgery as well as distraction osteogenesis. Because the condyle is not grown on the ipsilateral side, so you have to put the distraction on the same side, and you have to do distraction osteogenesis on the same side. By distraction osteogenesis, once the bone has been formed, then you have to do the orthognathic surgery because the facial height on the ipsilateral side is reduced. So by doing the lipotome osteotomy and bilateral sagittal split osteotomy, you have to increase the facial height as well. So you have to do TMJ surgery to release the TMJ ankylosis. You have to replace the ankylotic chunk with alloplastic TMJ temporomandibular joint that is made up of titanium. The condyle is made up of titanium, and fossa is also made up of the resin material. Okay. After that, you have to do distraction osteogenesis for the growth of the mandible. And to address the facial asymmetry, you have to do orthognathic surgery. By the surgery is indicated lipotome osteotomy in maxilla and sagittal split osteotomy in case of mandible. Though it is less common in Nepal, most of the cases are not done here. But recently, few cases has been done, and we have already done few cases. We are starting with a TMJ replacement as well. Another thing is hunting bow effect. The mandible is similar to a hunting bow in shape, the strongest in the midline symphysis and weakest at both the ends in the condyle. The anatomy is like that. It is thick in the symphysis region and comparatively it is thin in the condylar neck region. So trauma over the anterior region of mandible will lead to fracture of condyle. Its shape is like a hunting bow. That's why it is known as hunting bow effect. So whenever there is trauma in the symphysis region or parasymphysis region, angle region, even though there is no any trauma in the condyle region, the condylar neck will get fractured. So whenever you find any fracture in the symphysis or parasymphysis region, you have to look for another fracture as well. Okay. So whenever there is trauma in the chin region, anterior region, okay, compression will take place in the labial surface and tension zone is created in the lingual surface. So fracture will always start from the tension area. The fracture line will start from the lingual surface and it will reach to labial surface as well. So clinically, if you find some fracture in the symphysis, parasymphysis region, or if you find any fracture, you have to source for another fracture. And usually, in case of plain radiograph, if you see the OPG, the fracture is not clear. So you have to be careful. The pattern of condyle fracture in most of the cases, condyle fracture is not isolated. It is always associated with other fracture. We also did one research, and we have also found more than 94% of cases are associated with other fracture. Only 6% of cases were isolated condylar fracture. So condylar fracture may be associated with body fracture, contralateral side body fracture, or bilateral condylar fracture may be associated with symphysis fracture, or ipsilateral condylar fracture may be associated with contralateral angle fracture, or there may be isolated bilateral condylar fracture. But the isolated condylar fracture is rare. It is less than 10%. So in more than 90% of cases, condylar fracture is always associated with any other fracture. It may be symphysis fracture, parasymphysis fracture, body fracture. It may be contralateral. It may be present on either contralateral side or present in the ipsilateral side. It depends on the direction of force and magnitude of the force. If you see the etiology of condyle fracture, it may be associated. It may be due to either assault or road traffic accident, fall, or a sports injury. Mechanism of injury. So it is of three types. In first case, the kinetic energy imparted by a moving object through the tissue of a static individual. This commonly results from trauma sustained from a fist during sporting activities or in the course of some industrial accident. So here, the object is mobile. The object is mobile, so it imparts the kinetic energy to the static individual. In another case, the kinetic energy derived from the movement of the individual and expended upon a static object. This is exemplified by fall during an epileptic fit or following a faint when the patient is unable to protect the face with an outstretched hand, as in the case of so-called parade ground fracture. In this case, the individual is in motion, so it imparts the kinetic energy to the static object. Okay. In third case, both object as well as the body is in motion. So both the imparts a high amount of kinetic energy, it will lead to severe injury. So kinetic energy, which is summation of forces derived from a combination of previous two, and therefore generally produces a more severe type of injury, such as typically occurs in road traffic accidents. So both the object as well as body is in motion, so it will create a high amount of kinetic energy, and such injury will lead to severe fracture. And in such cases, there are multiple fractures. And most probably there is comminuted fracture. So in case of condylar fracture, in unilateral cases, the midline of the chin and the mandibular teeth are deviated to the ipsilateral side of a fracture. There is posterior open bite on the contralateral side, and the patient is unable to close the mouth. You can see in the first figure. Here, right side of the condyle is fractured, so it will lead to contraction on the ipsilateral side due to contraction of the masseter muscle and medial pterygoid. On the same side, there is shortening of the ramus height. As there is shortening of the ramus side, there will be premature posterior contact in the molar region, so it will lead to posterior open bite on the contralateral side, and midline will be shifted to the same side, ipsilateral side. Okay, when the condyle is fractured, okay, once the condyle is fractured due to contraction of the masseter muscle and medial pterygoid muscle, it is pulled superiorly. As the ramus is pulled superiorly, the ramal height will be decreased. There will posterior premature contact in the molar region. So as there is posterior contact in the molar region, premature contact in the molar region, it will create posterior open bite on the contralateral side, and midline is shifted to same side, ipsilateral side. So clinically, you will find there is contralateral open bite on the posterior region, posterior tooth. Midline will be shifted to the same side. There will be premature posterior contact on the ipsilateral side, and ramal height will be decreased. If you see the such clinical finding, you may suspect it is a case of unilateral condylar fracture. So when the fracture is bilateral, there is no displacement of the midline, but the chin is protruded in the occlusion gag posteriorly with a marked anterior open bite. But in case of bilateral condylar fracture, both sides the condyle is fractured and it is displaced medially. The ramal height will be decreased due to contraction of bilateral pterygomasseter sling due to contraction of masseter muscle and medial pterygoid. Bilaterally, the ramus height will be decreased. There will be bilateral premature contact in the molar region, so it will lead to anterior open bite. Okay. There will be no, the midline will not shift to any side. There will be anterior open bite. There will be premature contact and bilaterally anterior open bite will be present and ramal height will be decreased on both sides. So it's easy to identify whether it is unilateral fracture or bilateral fracture. In case of unilateral fracture, midline will be shifted to the same side. There will be premature contact on only one side. On the other side, there will be open bite. But in case of bilateral fracture, there will be premature contact on both sides. And there will be presence of anterior open bite. Midline is not shifted. The bilateral fracture of the condyle is usually caused by a blow to the point of chin. It is commonly associated with parasympathetic fracture of the mandible. Such a combination fractures commonly results from a fall onto the point of the chin following sudden loss of consciousness, as in case of epilepsy, the so-called parietal ground fracture. Okay. Commonly, you will find that the bilateral condyle fracture or unilateral condyle fracture is associated with anterior mandibular fracture. It may be sympathetic fracture or parasympathetic fracture. If the point of trauma is present directly on the chin in the midline, there will be, in such cases, there will be bilateral condylar fracture. If the point of trauma is either on the left side or right side, then in such cases, there will be unilateral fracture, unilateral condylar fracture. Let's say if there is left side parasympathetic fracture, then it will lead to trauma to the right side condylar fracture. And such fracture is known as parietal ground fracture because it is commonly present in army personnel. Moving to classification of condylar fracture, anatomically it is divided into three types: condylar head fracture, condylar neck fracture, and subcondylar fracture. Condylar head fracture is present within the capsule. Inside the capsule, the condylar head is fractured. The fracture lines runs from the superior surface of the condylar head. Okay, it is condylar head fracture. The fracture is present within the TMJ capsule. Okay. In case of condylar neck fracture, the fracture is present outside the TMJ capsule. It is present above the sigmoid notch and it is present outside the TMJ capsule. If the fracture is present in this region, it is known as condylar neck fracture. In case of subcondylar fracture, fracture is present below the sigmoid notch. Now, how will you distinguish whether it is condylar neck fracture or subcondylar fracture? Because both the fracture is present outside the TMJ capsule and both the fracture starts from the sigmoid notch area. And practically most of the fracture are oblique fracture. You will not find any straight fracture. Whether it is sympathetic fracture, parasympathetic fracture, or midface fracture, most of the fracture are oblique. They are in zigzag pattern. They rarely will find any straight fracture. So how will you distinguish whether it is condylar neck fracture or subcondylar fracture? So for that, you have to draw one straight line on posterior surface of ramus of mandible. It is known as tangent. You have to draw a tangent on the posterior border of ramus of mandible. Then you have to draw a perpendicular line from the lowest point of the sigmoid notch to this imaginary line. Okay. First, you have to draw tangent on the posterior surface of the ramus of mandible. Then you have to draw another perpendicular line starting from the deepest point of the sigmoid notch. Okay. Once you have drawn these two lines, then you have to see the fracture line. If more than 50% of the fracture is present, this is present above this line, it is known as subcondylar fracture. If more than 50% of the fracture is present below this line, then it is known as subcondylar fracture. If it is above, it is condylar neck fracture. If it is below, it is subcondylar fracture. Okay. It's simple. Just you have to draw two imaginary line. One line should be drawn tangent to the posterior surface of the ramus of mandible, posterior border of ramus of mandible. Then you have to draw another perpendicular line starting from the deepest point of the sigmoid notch. After drawing this line, you have to see the fracture line. If more than 50% of the fracture line is present, fracture is present above this line, then it is known as condylar neck fracture. If more than 50% of the fracture is present below this line, then it's known as subcondylar fracture. Previously, it is also known as high condylar neck and low condylar neck fracture. Low condylar neck fracture is also known as subcondylar fracture, but nowadays it is known as subcondylar fracture and condylar neck fracture. The clinical features of condylar fractures. There will be preauricular pain, okay, laceration over the chin and preauricular area, because most of the condylar fracture is due to trauma over the anterior region of the mandible. So there may be presence of laceration or abrasion in the anterior region of the mandible. Preauricular swelling may be present due to presence of hematoma or ecchymosis. Condylar movements are not palpable. If you place your little finger in the external auditory meatus and if you advise the patient to open and close the mouth, you will not find it, or you will not feel any condylar movement. Okay. Occlusion may be deranged in case of ipsilateral fracture or unilateral fracture. There will be ipsilateral premature contact in the molar area, and there will be open bite on the contralateral side. Concomitant mandibular fracture may be present in most of the cases. Most of the condylar fracture is always associated with anterior mandibular fracture, whether it is symphysis, parasymphysis, body or angle fracture. Rarely you will find the isolated condylar fracture. So in first case, as you can see, there is anterior open bite, bilateral premature contact is present in the posterior region. So whether it is unilateral fracture or bilateral fracture, it is unilateral fracture. No. First case is bilateral fracture. Because on both sides there is premature contact, there is anterior open bite. In second figure, as you can see, this open bite is present on the right side, but in left side you can see all the tooth are in contact, there is premature contact. So it is a case of unilateral condylar fracture on left side. Now, once you have examined the case, if you suspect any fracture, if you suspect there is condylar fracture, then always you have to take radiograph. Whenever there is mandibular fracture, you have to take two plane radiograph perpendicular to each other. The X-ray should pass perpendicular to each other, because sometimes what happens, if the fracture is undisplaced, you may miss the fracture. So it is advised that you have to take two radiograph where both the X-rays should pass perpendicular to each other. So commonly in case of condylar fracture, we advise OPG and PA view. Okay, if NCCT scan is available, it's better to perform NCCT phase. And to operate any condylar fractures, you have to do NCCT phase, because you have to know the area of displacement, nature of fracture, you have to reduce it. So you must have to do NCCT phase to operate the case. For diagnosis purpose, you can do just a plain radiograph, OPG and PA view is sufficient. If there is no fracture, no need to worry. If there is fracture, then if you are planning to operate the case surgically, then you have to go for NCCT phase. NCCT phase means it's normal CT scan. CT scan is of two types. One is non-contrast enhanced, one is contrast enhanced. We say NCCT and CECT. CECT or contrast enhanced CT scan is advised for any pathology like ameloblastoma or endogenic keratocyst, osteoid necrosis. If any pathology is there, if you want to know the extension of such pathology, then you have to do a CECT, contrast enhanced CT scan, where the contrast media is injected into the vein in the blood, and after that the CT is taken so that you know the extension of the lesion. And most commonly, if there is a vascular lesion, arteriovenous malformation or hemangioma, then in such cases, or if there is an incisional bone cyst where we suspect the lesion is containing blood, then in such cases you must have to do contrast enhanced CT scan, where the contrast is placed in the blood. After injecting the contrast media, CT scan is taken. So in film you can find the radio opaque area in the lesion due to presence of such contrast media. Okay, but in case of normal trauma or fracture, contrast is not required. You have to do normal CT scan, non-contrast enhanced CT, NCCT. So the OPG of a patient is shown in this figure. What is the significant finding in this case, other than the impacted tooth? We are talking about the fracture bone. Is there any abnormality in the bone, or it's fine? के छ के एबनर्मल छ कि नर्मल नै छ ठिकै हो
There is a fracture in condylar region.
which side right side or left side
The left side.
yeah left side there is you can see the radiolucency present in the subcondylar region okay the fracture line is started from this area and it has reached to the posterior border of the ramus of mandible so it is minimally displaced or we can say undisplaced left subcondylar fracture of mandible and in clinical scenario we will not find more clear cut fracture line it is the OPG of our patient so clinically you have to be careful you will not find the clear cut margin or in most of the cases the condyle is even though the condyle is displaced but you can't determine it in the plain radiograph you have to do CT scan in most of the cases the condyle is displaced anteriorly and medially due to action of lateral pterygoid muscle but for that you have to do the CT scan the coronal section in plain radiograph you will not find the clear picture okay so you can see the radiolucency present in the subcondylar region it is a case of left subcondylar fracture and as you know if you find any condylar fracture you must have to see whether there is presence of any fracture or not because in most of the cases condylar fracture is always associated with other fracture in the mandible only less than 10% of the cases you will find the isolated condylar fracture so is there any other fracture in this mandible symphysis here maybe can you see the radiolucent line in this area the oblique line the curved line it is right parasymphysis fracture okay you can see radiolucency is present in the lower border of the mandible okay it arises from the periodontal ligament space of canine area and it is oblique sometimes what happens when you see such fractures you will find two fracture line two radiolucent area so don't be confused it is not a two fracture okay what happens the buccal cortical plate and lingual pedicortical plate fractures are two different sides so in radiograph you will find the two radiolucent line it is not a two fracture it is single fracture but the radiolucent line you see at different reason the buccal cortical plate is fractured at different site and lingual cortical plate is fractured few millimeter at different site so even if there is single fracture you will find two radiolucent line in the radiograph okay this is the coronal section of CT scan of condylar fracture what is the significant finding in this case condyle fracture on the right side in CT scan as you know there are four sections coronal section sagittal section and axial section as well as there is VRT image the 3D image so in case of condyle if you are suspecting a condyle fracture you have to see the coronal section it is more clear and you can see the condyle is fracture and it is deviated to 90 degree there is 90-degree deviation okay condyle fracture is very interesting to treat because it is very difficult. Previously, none of the condyle fracture was treated surgically due to presence of facial nerve in that area. You have to approach from the retromandibular area where there is presence of all the branches of facial nerve. There is presence of retromandibular vein. There is parotid gland. You have to go through the parotid gland. You have to transect the parotid gland. You have to remove the masseter muscle. Then only you can reach to the condylar region. And the complication associated with condylar fracture is it may lead to facial nerve palsy, you may damage then some branches of facial nerve, you may rupture the retromandibular vein, you may damage the parotid gland, so it will lead to psilocele, or you also say parotid gland fistula. It's difficult to operate. So in case of management of condylar fracture, there are three schools of treatment. So previously, most of the condylar fracture was treated by non-surgically, just do IMA. Rested immobilization was the main aim of treatment, main principles of treatment, but the scenario has changed now. Nowadays, most of the condyle fracture are treated surgically, because if you treat the condyle fracture, let's say in this case, if you treat the patient non-surgically, if you put the patient in IMF for 2 to 3 weeks, and if you release it, the problem is patient will have deviation, because on one side, on left side, the condyle is normal, on the other side, there is no stop on the superior surface. So what happened on this side, on right side, due to contraction of pterygomastoid sling, the ramal height will decrease, so it will lead to facial asymmetry. Whenever the patients open the mouth will deviate to the same side, it's lateral side. Also, there will be premature contact on the same side. That was the problem. So one aim of treatment is, or one option is non-surgical treatment. Just do IMF intermaxillary fixation for few weeks, and then advice for mouth opening exercise. Another is functional treatment or active movement. It is advised for pediatric patient if the patient age is less than 12 years. In case of pediatric patient, surgery is not indicated, and you can't do IMF in case of pediatric patient, because it is said that if you do IMF, if you do immobilizing the pediatric patient, chances of TMJ ankylosis is very high. The ankylotic chunk will form and it will lead to TMJ ankylosis. So in case of pediatric patient, intermaxillary fixation is not advised, as well as surgery is also not advised. You have to treat them by functional treatment. You have to advise for active mouth opening exercise. On that is surgery, open reduction, internal fixation. Just open the fracture site, explore the fracture, reduce it, and fix it with plate and screw. That is the best. Now, there is something called restitutional remodeling. It is present only in case of pediatric patient. In case of child, condyle in children have the ability to undergo remodeling following trauma, and gradually with time and unaltered function, new condyle seems to appear, and this phenomenon is known as restitutional remodeling. Okay, due to presence of huge amount of osteogenic cells and good remodeling capacity in pediatric patient, even though the condyle is fractured, the new condyle will be formed. You don't have to do anything. Neither you have to do surgery treatment, nor do you have to do intermaxillary fixation. Just advise them for mouth opening exercise, new condyle will form itself. You don't have to worry. And this process is known as restitutional remodeling. So restitutional remodeling is present only in case of pediatric patient. This problem has been asked many times. Restitutional remodeling phenomenon is present only in the pediatric patient. It refers that whenever there is condyle fracture, the new condyle will form itself with time. So there are some guidelines when to operate surgically, when you don't have to operate, when you have to operate non-surgically, or when you have to treat them by functional method. So there are 4 conditions where absolute indication for surgery. In these 4 conditions, you have to operate. You have no option. You can't operate. You can't treat such patients with non-surgical treatment or IMF, like condylar displacement in the medial cranial fossa. If the condyle is fractured and if it has been displaced into the medial cranial fossa, into the cranial cavity, then you have to do surgery. You have to operate the case and remove the condyle. You have to fix it. Okay, the first condition. And it is true for both the pediatric patient as well as adult patient. Though practical, it's rare, but if it is present, you have to do that. So you have to know the theory. Second condition is invasion by foreign body. Foreign body is present in the TMJ area. If it is blast injury, bullet arm injury. So in such cases, if there is presence of foreign body in the TMJ area, then you have to operate the case with surgery. You have to the TMJ. Lateral extracapsular displacement of condyle. If the condyle is displaced laterally, if the capsule is ruptured, then also you have to open the TMJ. You have to treat surgically. These are absolute indications. The last one is malocclusion, not amenable to close reduction. Example, functional reduction of ramocyte. Due to functional reduction of ramocyte, if you have done the intermaxillary fixation, but you could not get the occlusion. If the malocclusion is still there, then again you have to do surgery. Other than these 4 conditions, you don't have to operate. But in these 4 conditions, you must have to operate, whether it is pediatric patient or adult patients. But luckily, fortunately, you will not find such cases practical. It's very rare. Okay. Now, second condition is strong evidence for open reduction. You can operate non-surgically, but it's better to operate by surgery, open reduction. Like if there is bilateral condylar fracture, If gross condylar displacement more than 45-degree deviation, severity is placed. If the deviation of the condyle is more than 45 degree, as you have seen in the last slide, here the condyle, what is the angle between this ramus and the condyle? I think it's about 80 to 85 degree. You have to draw two lines, one imaginary line, you have to bisect this ramus, another line, you have to bisect this condyle, and you have to see the angle between these two. Okay, if it is more than 45 degree, then it's always better to operate by surgery. Anatomic reduction of ramus height. If the loss of ramus height is more than 2 mm, as there is condyle is fractured, the calicomastoid sling will pull the ramus superiorly. So due to this, the ramus height will be decreased. If the loss of ramus height is more than 2 mm, then it's better to operate them surgically. Because if you don't operate them, then it will lead to facial asymmetry again. Condylar fracture with an unstable base. If it is associated with midface fracture, if the midcell itself is fractured, you can't get the proper occlusion because midface is also fractured. So in such cases, it's better to operate surgically. Unstable occlusion, like in case of periodontal disease, less than 3 teeth per quadrant. In such cases also, again, you will not find the occlusion because the most of teeth are missing. Due to periodontal disease, teeth are mobile. And if only less than 3 teeth are present per quadrant, so you could not get the occlusion. In such cases also, it's better to operate surgically. The last one is condylar fracture, for which adequate physiotherapy is impossible. Like in case of psychiatric patient, where we can't advise any instruction, they will not follow the instruction. In such cases also, it's better to operate surgically. So in this condition, it's always better to do surgery rather than non-surgical treatment. You can also treat a non-surgical treatment, but it is better to do surgery. So it is called as a strong evidence for open reduction. Next is mixed evidence for open reduction. You can do both, either non-surgical treatment or surgical treatment, your wish. Both of them has same result. Moderate condylar displacement of 10 to 45 degree. If the deviation is between more than 10 degree and less than 45 degree. So in such cases, you can do both, either non-surgical treatment or surgical treatment. But if you do the non-surgical treatment, you have to put the patient in mandibular maxillary fixation for few weeks. So it will be more problematic for the patients. So it's always better to do the surgery. If the surgery facility is not available, then you can go for non-surgical treatment on it. You will get the same outcome, same result. Now the last condition, when to treat with close reduction, when the surgery is not indicated. On displaced fracture or incomplete fracture, if the condyle is fractured, but it is undisplaced, or if it is incomplete fracture. In such cases, if the condyle is not displaced, then in such cases, you don't have to operate. You can treat non-surgically. Isolated intracapsular fracture, if there is condylar head fracture, you can do open reduction internal fixation in case of condylar head. Because it is present inside the capsule, there is no any area where you can place plate and screws. Okay, but the condylar head fracture is not so common. In most of the cases, condylar neck or subcondylar fracture takes place where you can put the plate and screw. But in case of condylar head fracture, if there is condylar head fracture, you have to treat non-surgically. You can do open reduction internal fixation in case of condylar head fracture. Because in most of the condylar head fracture, there is a gross fracture. Condylar fracture in children, except for absolute indication, whenever there is condylar fracture in case of children, you have to do non-surgical treatment. Surgery is not indicated in pediatric patient, except for absolute indication. Except for these 4 absolute indication, it is 4 among these 4 conditions. If any one of them is present, then you have to treat surgically. Otherwise, in most of the cases, almost in all of the cases, pediatric condylar fracture is treated non-surgically. Surgery is not indicated. This question has been asked many times in the exam. Pediatric condylar fracture is always treated non-surgically. Surgery is not indicated. Next is reproducible occlusion without drop back or with drop back that returns to the midline on release of posterior force. This you have to check intraoperatively. Let's say if there is in most of the cases, the condylar fracture is associated with other fracture as well. So you have to operate the other fracture. Let's say if there is condylar fracture associated with parasymphysis fracture. So you have to do, or if open reduction internal fixation in the parasymphysis region, then you have to check the mouth opening and other problem. If you pull the mandible backward, if it Let's say if there is right condylar fracture and left parasymphysis fracture. We have done open adjustment interfixation in the left parasymphysis. After that, you have to open the mouth and you have to put backward pressure. If it goes backward posteriorly, then it is known as drop back. If drop back is present, if you release the pressure, if again it comes to its original position, then you don't have to operate. But if you put the backward pressure, if there is a drop back and on releasing the force, it can't come to its normal position, then you have to operate that case. This is a drop back, with drop back and without drop back. With drop back means when you put the pressure and if it could not come to its original position in forward position, then it is known as with drop back. In case of without drop back, even though if you apply the pressure, the mandible will not go posteriorly. It is known as without drop back. If the mandible do not go posteriorly, it suggests that the condyle fracture, which is fractured, is either undisplaced or it is maintaining its position. In such cases, you don't have to operate. Okay. Another indication is medical illness or injury that inhibits ability to receive extended general anesthesia due to any medical condition. Most of the cases, in case of geriatric patient, if the patient is more than 70 to 80 years, then in such cases, it's very dangerous to give the general anesthesia because patient may not revive. So if the patient is more than 70 to 80 years old, if the patient is suffering from COPD, chronic obstructive pulmonary disease, if the patient has uncontrolled diabetes mellitus, if the patient has any other medical problem where surgery is not indicated, if the patient is on immunosuppressive therapy or chemotherapy, in such cases, general anesthesia is not indicated. In such cases, you don't have any option, so you have to treat non-surgically. So overall conclusion is in case of pediatric patient, you have to treat non-surgically, never do the surgery. In case of adult, it's always better to do the surgery. It is better for patient. Within few weeks, patient will come to its pre-injury state. They can do the normal function or back to work. Okay. If you surgery गर्नुपर्छ भयो भने तर लकीली फर्चुनेटली यस्तो केसहरु प्र्याक्टिकली देखिदैन एकदम रेयर हो यो चारवटा कन्डिसन छ भने सर्जरी गर्नै पर्छ whether it is adult or pediatric that doesn't matter. It's like common sense ले पनि थाहा हुन्छ कन्डाइल नै मिडल क्यानल फोसा भित्र पसिसकेको छ भने यतिकै छोड्नै मिल्दैन. You have to operate. You don't have any option. Or if the condyle is displaced laterally, capsule नै rupture भएर बाहिर आइसकेको छ भने then also you have to operate. Even non-surgical treatment गर्दाखेरि occlusion नै आयो and you can't get the occlusion, then also you have to operate. Okay. TMJ itself is ruptured due to either bullet arm injury or blast injury, bomb injury, then also you have to operate. But such condition is rare. Fortunately, such condition will not find practically. Associated treatment for condyle fracture, these all are non-surgical treatment. How if due to any medical condition or due to any other reason, if you can't operate the case, sometimes what happens in case of road traffic accident, patient will have polytrauma. In case of trauma center or tertiary center, you will not find isolated mandibular fracture. The road traffic accident cases are associated with many other fractures. They may be associated tibial fracture, symphysis fracture, okay, hip fracture, head injury. In such cases, you have to treat the most serious condition first. If the head injury is present, you have to refer the patient to neurosurgery. Once the patient is stabilized, GCS is normal, then only you can operate for maxillofacial injury. In such cases, you can't operate the case. And most of the maxillofacial injury is associated with head injury. In case of if there is head injury, the GCS is low. If the GCS is low, you can't do anything. You have to wait. And unfortunately, in most of the head injury cases, they don't revive. The chances of death is maximum in the first 24 hours. If there is subdural hematoma, epidural hematoma, if there is intraparenchymal hemorrhage within the brain, if there is head injury, it's serious case. So you have to wait until and unless GCS is normal, patient revived. Once the patient is revived, GCS returns to normal, then only you can proceed for maxillofacial surgery. Okay. So it may be associated either neurosurgery or orthopedic surgery. Most commonly we get the case. So we don't get clear case. Okay. Most of the cases are polytrauma case. It may be either associated with head injury or may be associated with any other injury. Tibial fracture, femoral fracture, rib fracture, So you have to coordinate with orthopedic surgeon, general surgeon, neurosurgeon, and you have to operate accordingly. And what happened with most of the cases when we operate, both the orthopedic surgeon and we operate together. We operate in the maxillofacial region, they operate in the either leg region or femur region, tibial region. So that the good thing is patient do not have to undergo under general anesthesia 2 times. We can operate at the same sitting. And also the duration of general anesthesia. If both the surgeon operate at the same time, the duration of general anesthesia is very less. And as you know, the duration of general anesthesia increases, the chances of complication is also very high. Okay. So practically, whenever you get the case in the emergency room or trauma center, it is associated with multiple fracture, multiple injury. There may be soft tissue injury like liver laceration, pancreatic laceration. There may be abdominal injury, intra-abdominal injury. And intra-abdominal injury is also very dangerous because you can't see anything externally. From outside, you can't see any bruises or anything. But inside, there may be presence of internal hemorrhage. And if there is internal hemorrhage, patient will collapse. Immediately, you have to do laparotomy surgery. You have to open the abdomen and you have to see whether there is any bleeding or not. If there is some arterial or venous bleeding is there, you have to control that. So due to any reason, if the surgery, you can't do the surgery, then you have to do non-surgical treatment. So if the patient is young patient with a maximum remodeling potential, or pediatric patient, if the patient age is less than 12 years, then in such cases, you don't have to do surgery, just advise them for mouth opening exercise. So for mouth opening exercise, if you tell the parents or the pediatric patient who is less than 5 years old to open the mouth, to mouth opening exercise, they will not do because they don't understand. So you get the instrument like Heisters or something, or you have to advise the patient to open the mouth forcefully, because once the condyle is fractured, it is painful condition. Though the pediatric patient or children will not open the mouth, and if they don't open the mouth, if it is kept immobilized, the chances of TMJ ankylosis is very high. In such cases, you have to exercise them forcefully. You have to instruct the patient, and you have to keep it in the regular follow-up. You have to tell the patient to visit the doctor twice a week. And in each visit, you have to check the mouth opening. If mouth opening is not adequate, you have to forcefully open the mouth. Otherwise, gradually the mouth opening will be reduced, and in later case, after a few years or after a few months, it will lead to TMJ ankylosis. And the complication of TMJ ankylosis will be seen only after 10 to 15 years. Okay. And this is one of the case we have operated. What significant finding can you see in this case? It is a case of it is the OPG of pediatric patient we have operated, we have treated. You can see most of the permanent teeth are in erupting phase, tooth buds are there. It is the OPG of 8 years old patient. What is the significant finding? Is there any fracture? And don't expect something better X-ray than this. This is the practical. This is our X-ray of our patient. You can't find more clear picture in plain radiograph. If you need a more clear picture, you have to go for CT scanning, CCT phase.
So condylar fracture on the left side.
Okay, the condyle is fractured on the left side. As you can see, the radiolucent line present here, oblique line is subcondylar fracture. Anything else? Yeah. What about right side? Can you see the fracture? One condyle you can see here, on the condyle it is present. There are no two condyle. It is sagittal fracture of condylar head. In pediatric patient, condylar head fracture is very common. So condylar head is fractured sagittally. Okay. So one of the pieces The condyle which is present medially, the medial fragment has displaced anteriorly medially. That's why it appears as a two condyle. Because due to attachment of medial pterygoid muscle, one of the fragment has been displaced more anteriorly and medially. Another fragment is still there. So it is a condylar head fracture on the right side. Okay, this is posterior part, this is the anterior part. This is condylar head fracture, sagittal split fracture. And it has been displaced anteriorly medially. You can see the condyle is present just below the articular eminence instead of present in the fossa. Okay, so there is bilateral condylar fracture. What else? And what we know, whenever you find a condyle fracture, you have to suspect for any other fracture, because most of the cases condyle fracture is always associated with other fracture of the mandible. Symphysis fracture is there, yes.
Symphysis fracture, yes.
Yeah, this is a radiolucent line. And as I have told, you might see the two radiolucent line. This is one radiolucent line, another radiolucent line is present here. But don't be confused. It is not two fracture. It is the same fracture. One is buccal cortical plate fracture and the other is lingual cortical plate. Because the buccal cortical and lingual cortical plate is fractured at two different sites. It is not necessary both the fracture will take place in the same straight line. Practically, most of the fracture are oblique fracture. They are in zigzag pattern. Okay, you will not find a straight fracture. So whenever you find a two radiolucent line, don't be confused. There are two fractures. It is single fracture. One radiolucent line is for buccal cortical plate, and the radiolucent line is of lingual cortical plate. So here also you can find a two radiolucent line, but both of them are the same fracture. This is one radiolucent line, another radiolucent line is this one. Okay, one is of lingual cortical plate, another is of buccal cortical plate. Now, the case is symphysis fracture and bilateral condylar fracture. Okay, whenever two fractures are present, how will you name them? Let's see if there is, okay, the same case. If there is left subcondylar fracture and there is right, let's say parasymphysis fracture, imagine. Then how will you diagnose? What is your diagnosis? How will you write your diagnosis? This is left subcondylar fracture and right parasymphysis fracture. So what will be your diagnosis? How will you write the diagnosis? I mean to say, whether will you write left subcondylar fracture, right parasymphysis fracture, or right parasymphysis fracture and left subcondylar fracture? Which will come first? When you say the diagnosis or when you write the diagnosis, the anterior fracture comes first. So you have to say right parasymphysis fracture and left subcondylar fracture. The fracture which is present anteriorly has to be addressed first. Okay. Also, during surgery, when you are operating the case, you have to operate the anterior fragment first, but then only the posterior fragment is addressed. In case of condylar fracture, also you have to fix the anterior fracture first, then only we can fix the condylar fracture. Because in case of anterior, if there is even a 1 mm discrepancy in the anterior region, it will lead to malocclusion. The occlusion is very important. The functional function is very important. That's why you have to operate the anterior fracture first, then followed by the condylar fracture. In condyle, if there is, even though there is a discrepancy of few millimeter, it doesn't matter, because it is said that is indicated that if the deviation is less than 10 degree, you don't have to operate. You can treat it non-surgically. Because of the remodeling capacity of the condyle, nothing will happen. So whenever you are writing a diagnosis, when you say some diagnosis, you have to say the anterior fracture first. So in this case, it is symphysis fracture and bilateral condylar fracture, or more specifically symphysis fracture, left subcondylar fracture and right condylar head fracture. Now in this case, how will you treat? What will be your treatment plan? के गर्ने? बच्चा आयो 8 वर्षको, यो फिमेल पेशेन्ट हाम्रो, bilateral condylar fracture छ, symphysis fracture पनि छ. What will your treatment plan? What will you do? Eight years. So for condyle fracture, non-surgical treatment, you don't have to operate. You have to advise for active mouth opening. But there is symphysis fracture. What will you do for that? There is anterior fracture. If you advise for mouth opening exercise, or if you open the mouth forcefully, patient will have severe pain because of symphysis fracture. You can't do that. If you don't open the mouth forcefully, it will lead to TMJ and callosis. You have to do exercise. Then what will you do? It is not a hypothetical question. It is our patient. Most of the patients you get such patients. Most of the time you get such patients. Pediatric patient with condyle fracture and associated other fracture. So if you get a such case, then you have to operate for symphysis fracture. You don't have to do anything for condylar fracture. Okay. Under general anesthesia, you have to do open reduction joint fixation for symphysis fracture or any other fracture. If there is presence of parasymphysis, body angle, whenever there is another fracture, you have to operate for that. You have to do open reduction joint fixation for that fracture. And for condyle fracture, you don't have to do anything. Postoperatively, you advise for mouth opening exercise. That's all. Now the question is, how many plate will you put in the symphysis region in 8 years old patient? What happened? हजुर बुझिन सर्जरी गर्ने ओपन रिडक्सन इन्टर्न फिक्सन गर्नु अपरेट गरेर अन्डर जेनरल एनेस्थेसिया फ्र्याक्चर साइट एक्सप्लोर गर्ने सर्जरी गरेर प्लेटिङ लगाइदिने सिम्फाइसिस पारासिम्फाइसिस रिजनमा कन्डालले चाहिँ केही पनि गर्नु हुँदैन अपरेट गरिसकेपछि माउथ ओपनिङ एक्सरसाइज एडभाइस गर्ने नाउ द क्वेशन इज when you are operating for symphysis fracture how many plate will you put to where and what about the tooth word? If you put the plate at the superior subapical lesion, you will damage the tooth wards, erupting tooth word, permanent tooth word. The concept of Samfield's principle or two-plate anterior to mental foramen holds only for adult patient, not for pediatric. I have already told you, I think the day before study. In case of pediatric patient, you have to put single plate always at the lower border of mandible because you don't have to worry about the occlusal force, tension zone and compression because in pediatric patient, the functional force is very less. So never put plate at other places other than lower border of mandible. If you put the plate at the subapical region or in the body region or in the superior border, you will damage the permanent tooth word. In case of pediatric patient, you always have to put simple small mini plate only at the lower border of the mandible. Okay, two-plate concept is for adult patient, not for pediatrics. So in this case, you have to put single mini plate at the lower border of the mandible. That's all. And then you have to advise for mouth opening exercise. What about the plate? Again, you have to remove it after. You have to remove the plate after 6 months in case of pediatric patient. You can't leave the plate as it is because because the patient is in growing phase, the pediatric patient starts in growing phase. What will happen? Bone deposition will take place on the labial surface, resorption will take place on the lingual surface, and later it will lead to the plate will enter into the soft tissue. Also, it may hamper the growth of the mandible. Okay, so you have to do the second surgery and remove the plate. Now, this is the post-operative case. We have operated the case and placed a single mini plate at the lower border of the mandible with 2 screws on either side. You can see the fracture line is still there. It is immediate post-operative OPG, and we haven't done anything for the condyle. You can see the reducing line is still present in the left subcondylar region, and condylar head fracture is present on the right side. So, or if open reduction internal fixation is done only at the symphysis region. Okay, what is this wire? It's a bridle wire. Whenever there is fracture, the first thing you have to do is place a bridle wire. What will happen? There will be no interfragment mobility and the patient will have no pain. Patient will have severe pain due to interfragment mobility there because the periosteum has one of nerve supply. So whenever there is interfragment mobility, patient will feel a severe pain. In order to prevent that pain, it's always better to do bridle wiring. As it is a pediatric patient, and there you can see there is no, the deciduous lateral incisor has already been exfoliated, and permanent lateral incisor is not erupted yet. So we don't have any option. So we have placed a bridle wire adjacent to central incisor. Okay. If both the tooth has been erupted, it's always better to take two tooths on either side, two tooths on left side, two tooths on right side. Because in this case, if you take only single tooth and if you place the bridle wire, when you twist this bridle wire, you may luxate the tooth. The tooth may be extruded. Because in case of fracture, the tooth is also traumatized. The periodontal ligament is in weak stage, or it may be severed. It may have been traumatized. It may have been teared. So to be in safe side, it's always better to take two teeth on either side, central and lateral on left side, and again central and lateral on right side, in then place of bridle wire. In this case, there was no lateral incisor, that's why we don't have any option, so we put bridle wire adjacent to central incisor only. And bridle wire we have to place in all the patients, or adult patients as well. No. The same patients after 8 months, it's the same case. We have placed the mini plate at the lower border of mandible for the symphysis fracture. It has been healed. You can't see any other radiolucency. And the most important thing what we want to see is the anatomy of the condyle. You can see the condyle. Condyle is, there is no any fracture present. The condyle is normal. The whole condyle is formed. On both sides, you can't see any replacement line or any fracture. So in pediatric patient, you don't have to worry. Due to presence of restitutional remodeling, due to more healing capacity, the neocondyle is formed, and that process is known as restitutional remodeling. So in case of pediatric patient, whenever you find any pediatric patient, you don't have to worry. No need to operate. You leave as it is. Just advise them for mouth opening exercise. If they don't do the mouth opening exercise, it will lead to TMJ ankylosis. Just you have to be careful to prevent the TMJ ankylosis. This is a case of after 8 months. Same patients, after 8 months, it is a clinical picture. You can see the mouth opening. It is almost 4 centimeter. Okay, both the lateral movement, right side and left side, both sides, the movement is normal. They can perform all the excursive movement. This is the case we have operated. She was only 8 years old. Now, next condition, if the patient is a dented adult patient with unilateral condylar fracture, in such cases, if you can't do the surgery due to any contraindication, due to medical problem, or due to any reason, then you have to put the patient in IMF, intermaxillary fixation, for 2 to 3 weeks. After 2 to 3 weeks, advise them for again mouth opening exercise. It will heal. Okay. Again, adult patient with bilateral fracture, if both the condyle is fractured, again you can't operate due to medical condition or due to any other reason, then you have to do the intermaxillary fixation for 3 to 4 weeks. After 3 to 4 weeks, advise them for mouth opening exercise. It will be normal. Now moving to dentalist patient, if the patient has no any tooth, patient is old age, and due to old age or due to any medical problem, because as you know, after 40 to 50 years, patient may suffer from many diseases like diabetes, blood pressure, COPD. And due to such condition, if the patient is not cleared for general anesthesia, then you don't have any option. You can't operate surgically. Then you have to go for non-surgical treatment. And in case of geriatric patient, in old age patients, if the condyle is fractured, and then you have to see the clinical scenario. If the mouth opening is adequate, there is only some malocclusion or discrepancy in the occlusion, then you can just change the denture, because the occlusion which is present in the geriatric patient is artificial. You don't have to do anything, just change the denture, make new denture. That's it. You don't have to do intermaxillary fixation for condyle patient in geriatric patient. Now, most important surgical approaches is condylar fracture. It's very difficult. That's why most of the center will not do the condylar fracture surgically, because the most of the condylar fracture is operated surgically, and on surgical, when you perform the surgical treatment, you have to go from retromandibular approach. In case of retromandibular incision or retromandibular approach, the incision is given just posterior to the posterior border of the ramus of mandible, about 0.5 centimeter below the earlobe, and the length of the incision is 3 to 3.5 centimeter. Once you have incised the skin, then you have to incise the subcutaneous tissue, then you get the fascia, superficial musculoepineuritic fascia. We tell it as a superficial musculoepineuritic system. Once you have incised this fascia, then you will enter into the parotid space of parotid fascia. Once you give the incision in the parotid fascia, parotid capsule, then you enter into the parotid gland. Now, what happens when you enter the parotid gland? There is presence of all the branches of facial nerve. Facial nerve, when it comes out of the stylomastoid foramen, then it will enter into the parotid gland, right? Then first it divided into two major divisions. Temporofacial goes superiorly and cervicofacial goes inferiorly. So there are two main branches, temporofacial and cervicofacial. After few millimeters, again the superior and inferior branches further divided into total 5 branches. Temporal, zygomatic, upper buccal, lower buccal, maxillomandibular, and cervical branches. These 5 branches are the terminal branches of facial nerve. So whenever we enter the parotid gland, you have to be careful because within the parotid gland there is branches of facial nerve. You must not damage the facial nerve. If you damage the facial nerve, the facial expression will be gone. Okay. So what we do, we have to enter through the two main branches, the temporofacial and cervicofacial. Between the two branches, you have to dissect bluntly. You can't use any BP blade or cautery. If you use the BP blade, you may cut the facial nerve, or if you use the cautery, due to current of the cautery, you may damage the facial nerve. So you have to dissect blunt. It is a blunt dissection. You don't have to incise. You have to do blunt dissection. You have to take the blunt mosquito forceps and you have to transect it in the anterior posterior region. The movement is very important. If you do superior inferiorly, you may traumatize the facial nerve. So you have to dissect it anterior posteriorly. So parotid, you have to dissect completely parotid gland. Once the parotid gland is dissected, then again after that, which structure will come after parotid gland? There will be masseter muscle laterally. Medially, there will be medial pterygoid muscle. And both the masseter muscle and pterygoid muscle are attached at the posterior border of the ramus as well as inferior border of the mandible. Okay, and this area is comparatively less muscular, so you have to give the incision just at the posterior border of the ramus of mandible. First there is skin, then subcutaneous tissue, then superficial musculoepineuritic system. After that, parotid capsule. Once you enter the parotid capsule, parotid gland, you can't use any BP blade or cautery. You have to do blunt dissection anterior posteriorly. Once the parotid gland is entered, then you have to. Parotid gland has two fascia, one is superficial fascia and deep fascia. The parotid capsule has two parts. Okay, one is superficial, one is deep. In between those two capsules, there is presence of parotid gland. We have dissected. Once you have dissected the parotid gland, then you will enter into the deep parotid space, deep parotid fascia. After that, you will enter into the masseter muscle. At the posterior border of the ramus of mandible, there will be masseter muscle and junction of masseter muscle and medial pterygoid muscle. So you have to incise that pterygomasseteric sling. You have to give the. Now you can use the cautery or BP blade. You can't use the BP blade within the parotid, but still some chances of injury is there. So you have to be extra careful. After dissecting the posterior border of the ramus of mandible, now you have to dissect the masseter muscle laterally. Then you will enter the bone. After entering the bone, you have to explore the fracture. Once the fracture is explored, then you have to reduce it and then fix with mini plate and screw. So which type of plate and screw you can use, that we'll discuss now. That is the most common approach. The extraoral retromandibular approach is the most common approach. The problem with, as I have already told, it may damage the facial nerve, it may damage the parotid gland, it will do parotid fistula or psilocyle, or you may damage the just below the mandible, below the ramus of the mandible, there is presence of retromandibular vein. Okay, you may damage the retromandibular vein. So due to this anatomical structure, it's very difficult to perform the surgery from extraoral approach. And also the problem is there will be a scar mark post-operative, even though if you don't damage any of the salivary gland or facial nerve or retromandibular vein, but the scar mark is still there. So in order to avoid those complications, the condyle fracture can be treated intraorally, but it's very difficult. You have to use endoscope. You have to give the incision in the buccal sulcus. There are no any important anatomical structure. You have to dissect the mucosa. You have to raise the mucoperiosteal flap. Once the mucoperiosteal flap is raised, you can find the bare bone. Now you have to explore the fracture and you have to fix it, but it's very difficult. There's something called as transbuccal trocar. You have to approach it from extraoral. Another is for intraoral approach also. You can use this 90-degree angulated drill bit. You have to use 90-degree angulated drill operation handout and also 90-degree angulated screwdriver for operation. Have you seen? I hope all of you have seen the screwdriver. Most of them are stripped. But if you are planning to operate the condyle fracture from the intraoral approach, you need the angulated 90-degree angulated screwdriver as well as 90-degree angulated drill bit as well, so that you can approach from the interior region and then you can make the hole in the lateral surface of the condyle. It can be done intraorally, but it's very difficult. You need endoscope as well. You have to put the camera intraorally, then you have to see in the. You have to put the camera intraorally, then you have to see in the image in the screen, and you have to operate. For patients, it's easy. There will be no any hazards. They don't have any. They don't have to worry about the complications of parotid gland or facial nerve or retronuclear vein. There will be no scar mark because intraorally mucosa will heal very well, and even though there is some scarring in the oral cavity, it doesn't matter. This is intraoral with endoscope. Okay, you have to put the camera intraorally and you have to see the screen. You can see in the screen like this. Now the question is, how many plates will you put in the condyle? So there are many research. Some of them have put one screw, some of them have put many. Some of them have put a single plate. But the problem with a single plate, most of the plate has been fractured. The prognosis was not good. So the gold standard is you have to put a 2 plate. This is one of the best techniques. Just you have to put the 2 plate, one at the posterior border of the ramus of mandible, one and another at the just below the sigmoid notch. The plate which is present at the near the posterior border of the ramus of mandible, you have to put 2 screws on either side of the fracture line, and these screws should be monocortical screw, not bilateral. Bicortical screw is placed only with reconstruction plate. This is mini plate. You have to put a mini plate in this area. Reconstruction plate is not indicated in case of condyle fracture, because reconstruction plate is a thick plate. It is only indicated in the anterior region of mandible, where the occlusal force or masticatory force is very high, where the bone buttress is less. In case of condylar region, you don't have to worry about the bone buttress because the occlusal force or masticatory force is very less in this area. Okay. So 2 plates are placed, one at the near the posterior border of the ramus of the mandible, another at just below the sigmoid notch. The plate which is placed at the posterior border of the ramus of mandible, you have to put 2 screws on either side of the fracture line, and the plate which is present just below the sigmoid notch, you have to put at least 1 screw on either side. Okay. This is tension zone, this is compression zone. This is a standard technique. Now, there are various plate design. You can put either 2 plates or lambda separate plate. These are the recent advances. You can put because the problem with these 2 plate is you have to place 2 plate and 6 screws. If you use trapezoidal plate, you only 4 screws sufficient. And also this 3D plate and this 3D design plate are called 3D plate because the plate itself is not a 3-dimensional, but they are called 3D plate because it prevents the 3-dimensional movement of the condyle. That's why they are known as 3D plate. So 2 mini plate is a standard technique. Nowadays, more recently 3D plates are commonly used. Okay. Lambda plates are also commonly used on the trapezoidal plate, or you can use the other separate plate like this. So there are many options. So you just remember that the 2 mini plate is a standard technique. 3D plate is far more better than those 2 mini plates. We have also done the research in some patients. We have compared the 2 mini plates with trapezoidal plate, and our result found that the trapezoidal plate is far more better than the 2 mini plates. Because in some patients we found that plate got already fractured, and we have published our result in international journal as well. So among all those techniques, two mini plate is a standard technique. You can use either 3D plate like lambda plate or trapezoidal plate. You must remember these three. So this is our case. We have operated the condyle fracture with two non-parallel straight mini plates. Okay, one plate is placed at the posterior border near the posterior border of the ramus of mandible, where two screws was placed on either side of the fracture line. Another plate was placed just below the sigmoid notch, and one screw was placed on either side of the fracture line. Clinically, it's very difficult to get the accessibility. There are a lot of anatomical structure. If you try to open the surgical site more, you may damage the facial nerve. So you have to be careful. You have very less space between the two branches of facial nerve, temporofacial and cervicofacial, and you have to enter through that small space. If you extend your incision either superiorly or inferiorly, you definitely will damage the facial nerve. This is the case we operated. It is the case of right subcondylar fracture and left parasymphysis fracture. Okay, you can see the fracture line. It is not straight. It has started from the contralateral parasymphysis. Now it is straight, and again it goes down. Again it goes posteriorly. So it is oblique fracture. But in order to diagnose, we have to see the lower border of the mandible. It is passing through the left parasymphysis region. That's why we say it is a case of left parasymphysis fracture and right subcondylar fracture. We operated this case, and also we have told that if there are two fractures, then we have to fix one fracture with rigid fixation. The Sampis principle is not applicable if the fracture is more than one. If these multiple fractures, Sampis principle is not applicable. So we have to make one fracture as rigid. We have to treat one fracture as with a rigid fixation. Then we have to treat the second one. In this case also, and when we are treating the case with a rigid fixation, always the fracture which is present more anteriorly should be fixed with rigid fixation. Okay, so in this case also, in case of left parasymphysis fracture, we have put the reconstruction plate. Now the condyle fracture is treated with two mini plates. Now, this is the case of our research we have compared and we have done randomized control trial, and we have compared the two mini plates with trapezoidal plate. And our result was trapezoidal plate was far more better. There was no any fracture, there was no any complications, and the good thing is we have to use only one hardware and only 4 screws. If you use two mini plate, we have to use 6 screws and 2 plates. But in case of trapezoidal plate, it is a small. You don't need a large surgical site. Just you have to place 4 monocortical screws, and this is a trapezoidal separate plate. And these screws are also monocortical screws, just 6 mm. Sometimes we can use 8 mm screw, 2 by 6 mm or 2 by 8 mm. This is the case of, again, preoperative OPG. There is, you can see the clear-cut fracture line. Again, you can see this radiation line is more clear. Another radiation line is also there, but this is somewhat not so clear. It is faint. Again, don't be confused. It is not a two fracture. It is same fracture, single fracture. One radiation line is of buccal cortical plate, another line is of lingual cortical plate. So it is a single fracture. You can see at the lower border, both the fracture line meets at the same point. At the lower border, both the fracture are present at the same point. But the buccal cortical fracture is present somewhat posteriorly. Lingual cortical plate fracture is present somewhat anteriorly. Again, you can't distinguish which one is buccal, which one is lingual. Just you have to assume that one is buccal, one is lingual. You don't know which is buccal, which is lingual. If you want to see which fracture is buccal, which is buccal cortical, which fracture is a buccal cortical plate, which is of lingual cortical plate, you have to do CT scan and you have to see the section. In plain radiograph, you can't distinguish. Okay, this is the preoperative radiograph. In postoperative radiograph, you can see again there are two fractures. So whenever there are two fractures, we have to treat one fracture as with a rigid fixation. We have plates. Reconstruction plate at the lower border of the mandible and trapezoidal plate was used to fix the right subcondylar fracture. So complications of condylar fracture are, it may lead to malocclusion as with other fracture, disturbance of mandibular growth. If you damage the TMJ area, it will lead to hamper the growth of the mandible. TMJ dysfunction like TMD, temporomandibular disorder may happen. Ankylosis, obstructive sleep apnea. Okay, we'll discuss ankylosis tomorrow. What is obstructive sleep apnea? Have you heard the term before? No. In case of TMJ ankylosis, the mandible will not grow. If there is bilateral TMJ ankylosis on both sides, the TMJ will not grow. It will lead to retrognathic mandible because the condyle will not grow in case of TMJ ankylosis in pediatric patient. So what happened? The posterior pharyngeal space, which is present just behind the tongue, the posterior pharyngeal space is very less. So when the patient sleeps, as you know, there are many stages of sleep: stage 1, stage 2, stage 3, stage 4. When the patient or when the person is in deep sleep, all the muscles get relaxed. Okay, if the patient is in supine position, if all the muscles get relaxed, what will happen? The muscles which are present in the pharyngeal area will fall back and will lead to obstruction. The air will can't pass, so it will lead to a snoring and patient may arise. So that condition is obstructive sleep apnea. The oxygen is not sufficient, the respiration is not sufficient, that's why it's not an apnea. Obstruction means in deep sleep, when the tongue and other muscles falls back, the airway space is reduced, that will lead to snoring and patient can't sleep. And we have found many such cases. In such cases, we have to do the distraction osteogenesis, we have to put the drive the mandible forward. After that, we have to release the TMJ ankylosis and treat it. And then again, we have to do the orthognathic surgery. It is big surgery. It will take a long time. And it is one of the complications of TMJ ankylosis. Secondary to TMJ ankylosis, there will be obstructive sleep apnea. Have you seen any case of TMJ ankylosis here or no? No. Okay, we'll continue again with TMJ ankylosis on next class, the day after tomorrow.